I'd like to welcome everybody to May 9th Ecophilia presentation. Today we have, for me, a very special guest. I've asked, as I had mentioned, I've asked all my friends to give a talk, but this is a very special request. And this is my daughter that is going to kind of inform us, give us a talk. And we know that these talks are relatively informal. So if people have questions, they can certainly ask along the way or at the end. Uh, I've asked my daughter, Megan Harlan Fleischut, who is a genetic counselor, and you can see her titles. She's a certified genetic counselor at Sloan Kettering Memorial Cancer Research Hospital. In fact, she's the head genetic counselor at Sloan Kettering. And her mother and I are incredibly proud of that. Uh, just a little background on how Megan maybe got interested in genetic counseling, and I'll let her talk about how she actually got into genetic counseling. I had Megan as a student in my class at Wycliffe High School. Twice, in fact, for honors biology and then biology 2 AP biology. And at that time, I was starting to get interested in genetic counseling. I had taken some courses through University of Akron, and that introduced me to not only what genetic counseling was, but also to some genetic counselors from Akron Children's Hospital. And so I got very interested in that and started talking more and more about how genetics and our new understanding of DNA and RNA and how genes work is leading was going very quickly into the medical profession. So I introduced all my students to genetic counseling. Take a quick jump to when Megan was in college. She went to Ohio Wesleyan. She would call, of course, and talk to her mom. If she wanted to talk to me, I knew it was about either computers or biology. And I was happy to, she always talk to me, but I knew it was one of those topics. And when going into her second year, she was already a zoology major and saying, you know, I love animals, but I don't know that I want to work with them for a career. And I said, do you remember the genetic counseling? And I told her, I reminded her of our introduction to it in our biology classes, and linked her with my friend, the genetic counselor at Akron Children's Hospital. And so she did a quick summer internship, or at least observation there. And next thing we know, she's the head genetic counselor at Sloan Kettering. So I'm going to be quiet, and I want to hear all about genetic counseling from Megan Fleischut from Sloan Kettering Memorial.
Thank you so much, Rich, and nice to meet all of you. This is such a special group. Really, really happy and honored to be here today. So I do have to say, everything Rich has said is completely true. My introduction to genetic counseling was from him more than once, but it was fantastic that I had the opportunity then to spend time and kind of cater my whole 4 years of undergraduate training to being in this field. And this field is widespread, as I'll talk about it more in a moment, but I've chosen focus on cancer genetics my whole career, which I feel really fortunate since we're always learning more. And I've been at this institution for 18 years, and it's just vastly changed in terms of our knowledge and understanding. So we have a long way to go, but I like that challenge, and it's been challenging all along the way as we've learned so much and made so many more improvements in all facets of this field. So what is genetic counseling? It was a field founded really from a combination of different backgrounds of social workers, physicians, nurses, healthcare professionals, psychology, where it's the process of helping people understand and take this sometimes complicated information, and then relate to patients in an understandable and meaningful way that they can use the information. And one of the tenets of our profession was always non-directive genetic counseling, non-directive counseling, so that you were giving information to patients, but letting them then help inform their decisions, but taking into account all the facets of that individual. So, every different aspect of their belief system and their understanding and their perception of the numerical, quantitative aspects of the information, and kind of then make a decision. So that's still what we try to do, is giving them the information succinctly, but where they can use it to most benefit. We do have a lot stronger recommendations in cancer genetics. I'll should be sharing a little bit later on based on the information we know now, but we still explain it in such a way that the patients understand the why, and not just thinking that's something they have to do if they have a genetic predisposition. But the field really had originated in prenatal, so reproductive genetic counseling and genetics. That's where I had spent a lot of time in my observations during undergraduate training. Cancer has exploded and expanded so much in the last number of years. Cardiovascular genetics, we've learned a lot more. Neurology, ophthalmology, you name it, any specialty. There's obviously, we know more and more and learning more of what the genetic components can be for at least a subset of these disease types. So cancer genetic counselors is, again, where I'm going to focus, because that's what I do. That's what I've always done in my career, and I've been so fortunate to be able to do this and meeting with the patients. The patients are at exactly the heart of what we do. So we spend time meeting with patients who either have a high risk for hereditary predisposition, to have been born with a stronger genetic component or a mutation in a gene that would have predisposed them to develop certain types of cancer. So these individuals may have a personal history of a cancer diagnosed at an early age, or with multiple generations in the family of the same or similar types of cancer, or they have this strong family history. So they're unaffected, they're healthy themselves, but they want to know, what can I be doing proactively or on that early detection end, if not the preventative end, to try to prevent cancer from forming. So that's kind of who our target population is. It's, again, ever expanding, because I think so much more we've learned, but we think about 20% of cancers, not all types, but in general, 20% of cancers have a stronger genetic component, or this hereditary component that we can identify. So we help clarify the risk for the individual based on their family history, or if there's much information is known about their cancer family history or personal history. And then obviously can have family members participate in this. So I'll get to that part. We provide the information and then support networks to them. We assist with treatment decision-making, especially in those newly diagnosed individuals, where it can make have a very big impact and differentiation, which we'll talk about too. And then ultimately, we want to give them a roadmap or a guide map of here's what you should be doing based on this. If you test positive, even if you positive being having the stronger genetic component or mutation you were born with, or even if you have normal negative results, still kind of here's your roadmap. Here's what we suggest you do based on all of this information assimilated together, your test results, your family history, your personal history, kind of a lot of factors go into that. And we give them that summary in writing, where then they can take that and be cared for with their treating physicians or their doctors at other institutions if they're not staying here with us. We do talk a lot about research. There's tons of research studies. We're so fortunate to collaborate with many of the different physicians and laboratories here and nationwide, and then internationally too. Obviously, collectively, collaboration is so important. And then again, providing the information for the patient is who we're seeing, but then it's really about the family. So all of this information can have relevance to first-degree relatives, which are children, siblings, parents, but then even further, aunts, uncles, cousins, more extended family members. It can be very relevant for a large number of individuals. So we are always thinking of that when we're doing this, and really when we're talking to our patient, focusing on them first and making sure all their needs met, their understanding. But then if they do test positive, we help with the next step of what we call cascade testing, or testing of family members, getting that information to those individuals. And then sometimes it does have relevance for reproduction or family planning, depending on the gene mutation identified. I can talk a little bit about that. So what are the training requirements? What does someone need to do after they have Rich Ben's introduced the field to them? It's a master's degree program. It's 2 years. There are a few PhD programs, but not many in the country that you can specialize even further. But really, most of us have this 2-year degree that it gives you exposure to all facets of genetic counseling, not just the cancer genetics I've been focusing on, or will focus on. You do number of courses that I loved. It was just amazing. It was like 2 years catered to everything I wanted to learn, and really fascinating. I loved learning all of that. And then the clinical rotations, you would spend time with different professionals, genetic counselors at different institutions or hospitals affiliated with that genetic counseling graduate program in all the specialties. So you get exposed to everything. And then you also write a master's thesis during that 2-year time. So it's a really busy but stimulating, amazing experience. There's a lot more graduate programs in the country now than there used to be, but they still are pretty rigorous. So it's because they're such small programs, that it is something. Is there a question? It is something that is competitive in a lot of ways, and we've now been able to help members of our institution here that work in different fields get into graduate programs by getting experience with us, which is so rewarding and really fascinating to kind of help with that process on the other side of it. We do still recommend getting volunteer experience in a hospital, doing a crisis hotline, kind of all of those other opportunities, since it is more difficult to get experience one-on-one with a genetic counselor, which I was really fortunate to have quite a bit of many years ago. And then letters of reference, along with academic caliber and all of the pieces we know that would be required. Many programs do obviously require examinations as well, so you can get their scores. But my career path, again, I cultivated my 4 years of undergrad. I ended up doing a major in psychology as well, just because I loved those courses and they were fascinating, kind of had me out of the lab, as well as with a lot of my zoology and genetics classes in the laboratories. Best of both worlds for me, hands down, still is. Love what I do. And then I had all this fascinating experience. Again, Rich kind of helped me connect. And then from there, I built a different network. So I had exposure at the Children's Hospital at Akron, with amazing genetic counselors there, with prenatal genetic counselors locally. And then during my school year, I was able to work with a number of genetic counselors in Columbus that did prenatal genetics or cancer genetics. And that's where I really fell in love with cancer genetics and just all that's involved with the counseling and the whole field. So I had the experience that we needed, and really learned a lot from those experiences before grad school. And then during my graduate training, I was fortunate to be in a program where we went to 3 academic centers, and I loved it and really, again, experienced so much during that time. And then I've been a practicing clinical genetic counselor in cancer genetics for many years, and then here at MSK for 18 of those years. And you do get an American Board of Genetic Counseling certification by taking a board exam. It's now offered much more frequently than it was. Back then, you had to wait like 2 years after graduating to take the exam and sit for the exam. It was 2 days. Now it's much different, but certainly an important field and a part of the field. And then you maintain that certification. So you continue with continuing education units similar to physicians have CMEs. We have CEUs that we want to do anyway. And so maintaining that certification and recertifying every 5 years. So today I wanted to focus a little bit on then what we do in terms of the field of cancer genetics and talk about some of the major cancer predisposition syndromes. So syndrome meaning that there's more than one cancer associated in the families that we see. And we'll talk about a few of those with what we still most know a lot about, which is breast and ovarian cancer. It used to be called hereditary breast and ovarian cancer syndrome. There are other cancers associated with that. And then Lynch syndrome, which is colorectal cancer, uterine cancer, and a few other cancers as well. But there's many, many more we've learned about, and I'll kind of touch on some of that. And who should be getting tested. So who should be thinking about this really has expanded again a lot in the last number of years. We used to be very selective about who was getting testing, and it's become much more broad. It's not everyone, but it has expanded greatly based on what we've learned. What does cancer genetic counseling involve? I've talked a lot about that already, but we'll be touching on that. What genes are implicated? What does it mean to have a high penetrance gene, which means very high cancer risk, versus a moderate penetrance gene? You can kind of imagine what those penetrance is, the cancer risks associated that gradually increase as we age, but can be to a very high magnitude with the high penetrance syndromes in certain cancers. And then how do positive test results, meaning we found a mutation that you were born with, impact then the management and kind of what you should be doing. And that's really the heart of what we want patients to understand is, how can I use this information? How could this be beneficial to me and my family members? And then we have lots of collaborations and access to resources, which we're just so fortunate and still trying to build all the time at our institution, and again with many other institutions. So the genetic risk assessment is still kind of the core of what we're doing. We're assessing by taking in all the number of information that I talked about with the personal history, family history, medical factors. We take a full medical history from every patient. Even outside of their cancer risks, there are other factors that can modify things. When it's a patient that's had cancer, this may have an impact on their surgery or their treatment for chemotherapy or radiation. And then there's the surveillance and survivorship. So after someone's had cancer, what do they need to do next in terms of risk for other cancers? If they've had a personal history of breast cancer, for example, they may be at much higher risk for some other cancers. And we talk about what to do with those pieces here. So it's kind of the pre-surgical decision-making, the predictive, prognostic, and treatment implications we've really learned a ton about in the last number of years are still kind of at the tip of the iceberg because we want to learn more. And then cancer prevention, again, is ultimately where we want to be, not just on early detection. So we kind of come out with the whole family cancer risk assessment and then that roadmap I talked about. So in terms of our evolution of genetic testing, it used to be single genes. We did the BRCA1 and BRCA2. You might be familiar with those genes as single genes many years ago when I first started here, and it was taking a long time for test results. Now we do next generation sequencing, so we can do a large number of genes, one sample, so it's either blood sample or saliva sample to get the DNA, and then we can look at kind of all the genes that are associated with that individual's risks. And so these are very small. I'm not expecting you to see what the cancer or the gene names are, but it's really helped us learn extensively from the testing we're doing on patients and kind of what other than contributing with, again, this is where we're always looking to others in the field in the United States and outside of the United States in the literature of kind of what other centers have learned and then readjusting our panels and saying, should we be adding this gene? Here's the data to support this, and kind of do all those rigorous reviews routinely to make sure that our panel has everything that we want to be thinking about for our patients. And we'll be doing an update soon. So it really had changed from that single gene testing that was done for many years. In the last 11 years, we've changed and are still expanding it and improving it. So who's referred to clinical genetics? It really is a diverse group of referrals. It's patients that are going through treatment right now because they've had a diagnosis, patients that were diagnosed many years ago or even just in the last few years. And then, as I mentioned, those individuals, we say that they're unaffected. They have not, their cancer unaffected. They have not had any personal history, but do usually have another suggestive factor, such as a family cancer history or their risk factors. So diagnosis of cancer at a young age, particularly, it can vary a little bit for which type of cancer you're talking about, but usually under age 35 or even sometimes under age 45, depending on the cancer, is considered a very young age. The rare cancers that we still don't fortunately see in the general population very often, which are ovarian and pancreatic cancer, just those alone, just having a personal history of ovarian cancer, for example, itself warrants genetic testing. Same thing for pancreatic cancer and those first-degree relatives as well. Multiple diagnoses of cancer in one individual is obviously something that makes us suspicious of there being a stronger genetic component that has played a role in why that individual's had two or more individual tumors or cancers. Multiple relatives affected with, when we say related cancers, we put breast ovarian cancer together, or the colon and uterine, as we talked about with these syndromes that are known, and many other different facets with this. So that's something that makes us more suspicious. Ancestry, we've learned a lot about the last number of years, still have more to learn with the testing that we'll do, but we know individuals of Eastern European Jewish ancestry or Ashkenazi Jewish ancestry are at much higher risk for certain types of cancers based on specific, what we call founder mutations or more common gene mutations in that group. And that's just one example. Pathology report. So even the subtype of breast cancer can make a distinguishing factor for us to be more suspicious that there's a stronger genetic component. And triple negative breast cancer is an example of that. And then the immunohistochemistry or IHC and microsatellite instability or MSI testing are factors we look at in colorectal and uterine or endometrial tumors. We do try to test the person that's had cancer in the family first, but I think in the last number of years, that individual is not always available or interested in testing. Sometimes they've passed away. So we are able to test those first-degree relatives or family members, even if they haven't had a personal history. The downside to that is if my close family member had cancer and they're not able to get tested, and I test with completely normal results, that doesn't put my sister or other individuals around us in the family, aunts and uncles, it doesn't put them out of the risk category because my results are not truly informative for the family. We need that individual that had cancer to be tested, in that setting, ideally. But that's obviously all part of our counseling and what we make sure patients understand. And then we base recommendations based on their family history of cancer, even if their results were quote unquote normal or come back without a mutation. So these are guidelines that are always evolving. So today, this is what we're saying, but it may change very soon in coming months, again, with more knowledge in the field. So this is something that is always, again, a moving target, ever evolving, which is really honestly where it is something we're so happy to have contributed to a lot of this knowledge with our team's research efforts and again, collaborating with those all over the country and world. So there's many different guidelines, but we really go by the National Cancer Consortium guidelines, the NCCN. And so these are as March of 2024, but again, ever evolving. And some of the pieces I've already mentioned, just having one person. So in this middle category here, if you've had ovarian cancer, all patients those individuals that are affected, meaning have had cancer affected patients should consider genetic testing. And then over in this further category, the right-hand side over here, the cancer unaffected individuals, if they're a first or second degree relative of someone with ovarian cancer, should consider testing. So again, even if that individual is not available, they should consider their own testing or assessment. Pancreas cancer, all the patients we are trying to see and get tested here. And then first degree relatives right now. Male breast cancer is very rare, but does occur in the general population just by itself outside of a strong hereditary component. But certainly those individuals, we want to test all of them and see if we can find the answer. And then there are first and second degree relatives. And then this whole category for females with breast cancer. And we've now very recently expanded our criteria. It used to be under age 50 met the criteria, and now it's expanded to under age 65. There have been many years of discussion about this expansion. And so the American Society of Clinical Oncology, or ASCO, had put this forward at the beginning of the year, and it's taken a little while for the rest of us to kind of come around to truly doing this in practice. And part of the reason is insurance carriers also need to follow all these guidelines, and kind of we have to put together the justification, which is there, but just making sure the insurance companies then will pay for the testing is a big piece why this is such an important kind of summary of a lot of the cancers we know about. Again, it's not by any means all inclusive, but just kind of a snapshot of what the types of things we're thinking about. And again, for then the testing to be covered by insurance payers and carriers. So colorectal cancer, I want to talk a little bit about this. I mentioned the age can be different. So it's under age 50, a diagnosis of colorectal cancer under age 50. We certainly also then look at these tumor tissue testing that's done really routinely across the board on individuals with colon cancers. So if those results come back abnormal, then that gives us an indication genetic testing is warranted. So the blood or saliva testing we do based on that tumor tissue analysis. Same thing then, family members, we really want to have this testing. And endometrial cancer, we do the tumor tissue testing first, and then prostate cancer is something we've learned a lot about in the last number of years. So metastatic prostate cancer in particular is something that we're more suspicious that there's a stronger genetic component. And then certain types of we look at the pathology, so it's the histology, like the grading and the levels of the markers in the tumor can give us an indication whether there's a stronger genetic component or there should be testing considered to look for that. And then first degree relatives of any of the individuals that have this more rare type of prostate cancer or metastatic or the histology changes. So during a genetic counseling, we still look at the pedigree. The family tree diagram is so important to us. We're so visual in the field. So we're constantly now able to do these electronically, which is much nicer than hand-drawn that we did for many years and even until not that long ago. But now we do them in the computer. And then the nice thing is we can export it immediately into that patient's medical record so that it's accessible and editable by other healthcare professionals, that they can all see it. And then certainly the patient, as they need to make updates, they can get access to their family tree to make those updates there, and obviously in the written notes in the medical record. But this is still core of what we do. We take that full medical history I talked about and asking all kinds of questions about hormone exposure and many different things. We still do ask about history of smoking cigarettes, although many less people have that history nowadays, and kind of complete the whole risk evaluation with each patient, talk about what genetic testing is available to them, and kind of give them the why of, or how could I use this information? Why am I doing this testing? And then we do meet with them, of course, to talk about the results. Many patients at our institution are doing a research study that they've already had this tumor and blood paired tumor and blood testing. So they're coming to us just with the results disclosure of positive results or where we found a mutation. So that's really where I think we add the most value. And we pair the session where most of the time is with the genetic counselor, and then a physician joins the discussion as well towards the end for discussion of these medical recommendations and making sure that all the patient's questions are answered. So it's really nice to work as teammates with the physicians that we have here. Most of them are oncologists, but certainly all specialize in genetics. And again, making those targeted medical management decisions that are sometimes available to us at this time with the knowledge we have in the field. And we help the patients through this all along the way. So why is this important? We really see that obviously the benefits can be making an informed decision. That's where we want them to understand the impact on treatment. So for patients with breast cancer, there can be different reasons to consider based on factors unrelated to genetics, but certainly with genetics, it can help tip the scales of whether someone would have a more aggressive surgery or more complete surgery of mastectomy versus just lumpectomy, or considering bilateral mastectomy, removal of both breasts, all of the tissue as much as possible. Targeted therapies we've learned a ton about in the last number of years, which is really exciting, and whether someone's eligible to even consider this type of trial if they end up needing it, and immunotherapy. Risk for other cancers I mentioned. So just after having one diagnosis and putting that behind the patient, they may still be at risk for another breast cancer, for example, if they haven't had bilateral mastectomies, or for ovarian cancer I mentioned in that example. So we're still at risk for other cancers, just also have our general population risk for colorectal cancer in that setting, that type of thing. So that's really what that roadmap and the guidelines we provide to patients are individualized, but include all of the cancers that we want them to be thinking about. Family planning, there can be indications where in most of these cases, or most of these genes, cancer predisposition genes are inherited in a dominant fashion, so that we have two copies of the gene, but one has the mutation. In some cases, it's recessive. So that's something where we talk about then if an individual has just one copy of is a carrier, has one copy of the mutation, but if their spouse has a different mutation, but again, could be affiliated with different conditions. We're talking about that with patients a lot in different settings. And then also with the option for different gene mutations for patients to consider, especially if there is childhood onset tumors, which is very rare, but can happen with some of the gene mutations. There's the option for pre-implantation genetic diagnosis or testing of the embryos at the 3 to 5 cell stage. So very, very early in development, and then selecting only the embryos that do not have the mutation to go into the uterus for implantation and kind of proceeding with pregnancy. So that's technology that's been available for many years and just has been honed and improved in the last number of years as well. So we talk to patients about that, especially in the setting of that they are thinking about children in the future, and particularly when there's a childhood onset risk, like risk for cancer prior to adulthood. There's so much research. I could go and give a whole talk to you about that and the opportunities, but it's been really, really rewarding and exciting to see patients benefit from participating in research, and then just how our field has really expanded all over with collaborations. There's so much support and support networks here for patients that are going through this testing or identified with certain mutations. We've built some of those support groups, and obviously online helps a lot if it's not just our network here, but their family members can join, and certainly again then nationwide there's lots of support groups and conferences that are built for patients, which is really wonderful. The accurate interpretation of results is something we're also so focused on and is so important to us, why we think genetic counseling is critical to patients at some point that they touch us or meet with us or understand the difference between these positive results where there's a mutation that increases the cancer risk, negative results where they're, I'm saying normal, quote unquote normal, meaning the results didn't find any mutation, but that doesn't mean that there isn't another gene or discovery we'll make. So those patients are not completely at at general population risk all the time. And then these variants of uncertain significance that still come up, and really can be something that then we want to stay in touch with the patients every year or two. And so we really carefully counsel with those patients, but we would not recommend that those patients pursue a surgery in most instances when it's a straight uncertain result, because typically what these results will be is reclassified over time. So it may just be a year or two, or maybe longer period of time. And they're typically reclassified to be negative results where they're benign polymorphisms that make us different from another, not likely to be the deleterious or the cancer associated high risk, or associated with high risk, where we call them positive results. In some instances, they do get classified to positive results, but we're usually able to help the patients with the interpretation at this point of kind of which way the results are leaning based on all the factors that I just described: personal history, family history, lots of these other pieces, and what the laboratory can share about that particular variant that was identified. So it's really a piece of the part of the field where even at our institution alone, they just keep expanding the number of variant curators that do this work, because it's really important. And the more genes that you test for, the more variants you may find. So that's something we're obviously aware of and equipped to handle and help patients through. And then again, the identification of those family members who are at risk once a mutation's been found in the individual we're counseling is something we're talking to that patient about, and then help them navigate with getting those individuals tested. Even if they live all over the world, we can kind of help them with finding a local provider or getting the care through a research study we have. There's lots of different kind of options for that.
Meg, I have a question. Obviously, you aren't, if somebody is diagnosed with cancer, they don't automatically go to a genetic counselor. How do you get the connection with a patient that is found to have cancer?
It's really is kind of streamlined in a lot of ways now, where those patients, many of them, we have same-day referrals for the newly diagnosed breast cancer patients, for example. So we are usually seeing that patient the day that they meet the surgeon. So kind of they're new to our institution, because it's just something that can make such a difference for medical management decision-making. So there is like a referral or a handoff. We're kind of readily waiting for those patients, if you will, to see them same day or next day. But other types of patients at our institution, many times it will be that they did that tumor and blood testing with their referring doctor, so their oncologist or other treating provider at the institution, and then we have a whole system actually where we're checking this, but they get referred to us when the results are positive, and we don't see the other patients necessarily, unless there's a family history suggestive or some other factor. So it's really a online referral piece that they make internal referrals, and then we can obviously accept external referrals. There also could be self-referrals for patients, but when they're treated here, it's what I'm trying to say is there's a lot of different models where sometimes they already have testing, or they come to us for testing still, but it's a kind of a communication with the referring team, and then we're able to facilitate whatever the next steps needed.
Thanks.
That makes sense. So our models have shifted a lot. I've talked a little bit about this already. The traditional model was to see everybody before they had genetic testing, making sure with all of the non-directive tenets of our field and the pieces I talked about. So it was a really long, detailed session, even up to 2 hours when it originally started in the field. Now it's much more succinct, that they need to know all the heart of this information, but many patients getting this testing with their treating oncologist, for example, really want it for also, they want the tumor tissue testing for the treatment side of things, and then the blood testing or our DNA testing for so much more for future cancer risk, for what we just talked about. So we don't necessarily need to see all those patients up front. They're getting their testing already clicking, and then we're seeing them on the other side for, particularly, as I mentioned, positive results when there is more to talk about. And that's really where the field has been evolving. We still see lots of patients up front, again, self-referred patients or patients in many different situations where, again, that family member that had cancer may not be available. So those patients, I think, are still in a category where we do spend time with them up front, and no one has been tested in the family. But it's something that we've kind of shifted, talking about the shifting model. It's been called mainstreaming. So kind of being able to get to more patients and increase this awareness, and then be able to test more patients, and not be limited by having to sit down with a genetic counselor or have the awareness of what's available, because now it's something that has really been spread out. There's directed consumer testing in some instances, if that is something where a patient isn't able to get to a center to get testing. Again, I'm talking about our experience here at the institution. I feel very lucky. We really feel like we touch and care for so many of the patients that are taken care of here, but there are many situations with insurance or different providers and different things that that they can do that through the labs. The commercial labs have kind of set up genetic counseling in different situations for getting the care that patients need. And then really that post-test, that roadmap piece is important for patients. So I can talk a little bit more in depth, or are there any other questions? Because I realize I have a lot of slides. We don't have to go through tons of the detail, depending on if there's questions right now.
I had another question.
Okay.
You had identified as a group, the Ashkenazi Jews, the Eastern European Jews, and I understand, because that has traditionally been a relatively closed society, and I understand the genetics of like combinations. Are there other groups that are similarly affected? For example, Northeast Ohio, the Amish, very closed society. I know they have birth mutations for frequency, 6 fingers and some polydactylism.
Right.
But what about cancers and for other groups?
There are, and so I think it's more even down to the exact mutation. For example, so there's different mutations, for example, in the BRCA genes that we've found can have a much higher penetrance in individuals of South American, certainly Brazilian ancestry, or the Finnish population. There's been lots of that, but it's not in the same quite in terms of, the research that we've done. Our group particularly found one of the BRCA. Dr. Offa found the BRCA2 founder mutations, and we just have had such a focus on that group of patients that I think it's not been as big of a learning, if that makes sense, but there definitely are other groups. And we know that then, because the laboratory, when they do these curations and they put the reports together, they will say that, that it's very high incidence in this population, and that they're taking in the information that we've put in of the ancestry, whatever's known about the individual. So it's something, that's how we're building the knowledge too, if that makes sense, by testing more patients. But we tell the patients that have less common ethnicities, meaning not white Caucasian, for example, that are getting testing, they might be at a higher likelihood to have one of these variants of uncertain significance, not because of that it's uncertain, it's just because of our knowledge. And, we just haven't figured it out yet, if that makes sense. So I make sure that patients are aware that they might have more than one variant. All of us have probably a number of these uncertain results, or not uncertain results, uncertain variants of uncertain significance, not just for cancer, for different things, but that's something we want patients to be aware of, because then we will hopefully over time be able to reclassify these with more testing, with more knowledge.
Thank you.
I feel like I go really deep into information rich. I'm not sure what other slides might be of interest. Do you want me to kind of jump down to something else, like pancreas cancer, or what else would be of interest to the group?
Prostate cancer.
Prostate cancer, sure. Let me get there, and I'll share again.
There you go. Good.
So this has been something that 2016 feels like, when I see this, I'm like, it feels like yesterday when this study came out. But it was really, really, at the time, still obviously holds true, where we're learning more all the time, but that we had discovered in prostate cancer, the most common gene implicated is BRCA2, as you can see here clearly, but then in all the other genes that we now have part of our panel, even for breast and ovarian cancer, because we know prostate cancer, again, is under this umbrella when we would think of the BRCA1 and BRCA2 mutation carriers. We've known that for a long time, but we've now expanded the panel to include the genes ATM, CHEK2, PALB2, some of these other genes are part of our panels because of not just the risks for individuals to have breast and ovarian cancer, but to have prostate cancer. We also have a whole prostate cancer panel now that includes a lot of the genes. And one of the genes we have learned more and more that's not listed here, but has been implicated since that time is HOXB13. So it's another gene that can increase the risk to develop prostate cancer above that general population. This is obviously, and I apologize for the misspelling, enriched in men with metastatic disease, as we talked about. So we think right now, and again, this number may change because we're always learning, but about 12% of prostate cancers have the stronger genetic component. And prostate cancer screening can be controversial. So that's something we talk really carefully with individuals about and have them talk to their doctors. Because there's kind of pros and cons to everything, but pros and cons to the screening. It's not clear cut like a colonoscopy that if you have any polyps, you remove them, you can't get colon cancer. A lot of the other screenings are just not that clear cut. So it's something that we want to make sure individuals know, but those individuals in the high risk category obviously need to start the screening and start it earlier. So, with a brother with prostate cancer, an individual, their father, like multiple relatives in the family, even aside from a genetic predisposition, we want them to be diligent in starting the screening earlier. Pancreatic cancer, as I mentioned, is something that's so rare in the general population, but we've learned a lot more in the last number of years. At this institution and then many institutions across the country, we have a registry where patients participate in basically a research study to look at the best type of imaging for pancreatic cancer. So they'll do MRI imaging to try to pick up any lesions that may be need to be worked up or followed, and trying to be on that early detection end, because that obviously is really helpful and would be life-saving in many instances. But these are the genes that we've found that have been associated with increased risks. Colon cancer, I mentioned, we learned a lot about and that there's different categories. I've focused so much on this category where there's a stronger genetic component or one of these hereditary syndromes in a family, but family history also is, obviously important and a big piece here, where we don't necessarily find a gene mutation, but we know based on the family history, there's an increased risk that there's modifying genes or other factors. Obviously, always there's genetic and environmental factors playing a role, but what are those other factors or specific factors that kind of trigger it in families? It isn't always, one gene or a hereditary syndrome that's identifiable at this time. So we call those kind of familial cancer risks. And then sporadic, meaning general population. Obviously, we know that colon cancer is common. And this is true of all the cancers. So we really have, learned a lot with these cancer susceptibility genes and expanding panels. I can show you on the next slide in a moment. The importance, the somatic means the tumor testing, and the germline is the blood testing, the somatic and germline integration. So doing both of those has been incredible for help with treatment end of things, the therapeutic implications, but also then to try to be on that early detection or cancer prevention end. So these are a number of the genes that we've now expanded in thinking about. Polyposis is like a carpeting of polyps in the colon, or even just having a number of polyps identified over lifetime. And then there's the different histologies, the different types of polyps. Adenomas or adenomatous types of polyps are the precancerous polyps that we want to remove. Obviously, there can be mixed polyps. There can be hamartomatous polyps that are found in serrated polyps. And then there's other polyps not even listed on here that are benign or kind of hyperplastic and not associated with a genetic mutation. But I mentioned, so what's also interesting about this is that so many of the genes historically in cancer genetics were this autosomal dominant inheritance, but now we've learned so many more can be inherited differently in terms of recessive as well. So this is a lot about Lynch syndrome and cancer risks associated with Lynch syndrome. I've only mentioned colon cancer and uterine or endometrial cancer risks, and this is the different genes compared to the general population risk. So much higher risk when you've got a mutation in one of these four genes that are associated for colon or endometrial cancer, but also ovarian cancer, also a certain type of genitourinary cancer, the renal pelvis or ureter, gastric cancer, small bowel cancer, pancreatic cancer, less so, but sometimes in some of the families, and then the biliary tract tumor has also been found in some families. And we've been able to kind of elucidate the information based on the families that have each of these types of mutations. It's usually only one, unlikely to have more than one mutation in a family with Lynch syndrome. So it's based on the mismatch repair gene. And then this is that screening, that roadmap that then we recommend for the individuals. And I know it's hard to see all of it at once, but if you're looking just at the column for MLH1, for example, we would start colonoscopies between ages 20 to 25 rather than the general population age 45, and do them much more frequently, typically every year, as opposed to much longer intervals for general population, typically 10 years if it's no polyps are identified for an average individual. For females, there's a lot more discussion at different points after childbearing for even removal of the uterus can be considered, but removal of the ovaries and fallopian tubes, because we don't have good ways of screening for ovarian cancer. And then, completing these other screenings, the upper GI endoscopies as well. So we believe that this is, an integral component of oncology management now of all of our cancer patients, broadening of this clinical criteria as an ever-evolving work of ours, if that makes sense. Like I said, we're just even scrutinizing every few months and continually staying up with literature. That's why I feel so fortunate to be a part of a team of 9 physicians and 17 other genetic counselors. So we're, always wanting to learn more and just trying to stay up with that communication with many others at national conferences, and kind of been always carefully considering the panels and how we are doing testing for our patients. But it's been changing a lot, and it has been incredible. And again, then the family history of cancer itself is even broadening as we're learning more. The therapeutic actionability is an area that we really, really want to improve too, and has come a long way for certain types of cancer in terms of how we can target. If someone has a mutation, we can target the type of treatment. And then the identification of these syndromes really is life-saving for many family members that would have never had an idea that they were, a significant increased risk for cancer they didn't see in the family. So, for example, if someone has a family history of breast cancer, they wouldn't think about ovarian cancer unless they were tested and, found to have an increased risk. And after childbearing, removing the ovaries and fallopian tubes is obviously completely life-saving. That prevents the development of a fallopian tube or ovarian cancer. So that's the cascade testing we talked about for many family members. We do now have an expanding number of high-risk screening or surveillance clinics that are focused on the patients that don't have a personal history of cancer. And that's really been, again, an area where we want to expand more. And the Catch Clinic is if you will, encompasses lots of different cancer predisposition syndromes. So many of those patients can be covered for the basis of that whole roadmap I talked about, not just one type of cancer. RISE is a clinic that's focused on breast cancer imaging. So they do MRIs and mammograms for those high-risk patients. It's got many of the family members that we've tested or that have come to us from outside. The pancreatic cancer and pancreas surveillance I mentioned with MRIs. The renal registry is another one. And then many other cancers we're not even talking about today that we're continually trying to be on that early detection end for. So this is kind of the model of genetics is just one piece of this whole coordination for patients. And all of these other factors I didn't talk about, of course, that play a role in helping to make this more personalized for individuals are something we're considering and that are part of a patient's care in their journey. And then this is my team I mentioned that I feel really, really blessed. They are my hearts. As I say, I really wake up every day invigorated to come to work with these individuals and cannot say enough about that. It feels like a family. We then have a number of research and administrative team members we work closely with that are not here. This is just the physicians and genetic counselors, my clinician teams, but this has been such a phenomenal experience, and I really, really love doing this. I'm learning all the time.
Other people with questions, I feel like I'm asking all the questions, but I have more in case I don't get to ask these questions when we get together as a family. We talk about other things like the kids and such, and other people with questions. Well, then I'll continue. The one I noticed was the BRCA1 and BRCA2 genes. and that they show up in a number of different cancers. Do we understand? I mean, I think I understand a little bit about the mechanism of what the BRCA gene does, but can you talk why it's so involved in so many cancers?
It's a great question. So they're tumor suppressor genes, and so when they are knocked out, if you will, it kind of one copy of the gene is you're born with the mutation. Then it kind of, let's say this knockout model, it's the two-hit hypothesis. Then it puts you at high risk. I'm sorry, I'm getting messages from a colleague that I have to answer really quick.
Go ahead.
Sorry. Sorry, it's about clinic is going on right now.
No, that's fine.
So that kind of is what increases you're already like halfway there, if that makes sense, increases the chance that then other modifying genes, which we have discovered and it's been helpful in kind of honing the risk for BRCA mutation carriers, particularly because that's an area we have more expertise in. And I can explain what led us to that in a minute. But that's where then environmental factors obviously play a role in what ultimately leads to that second hit and can lead to the tumor development. We had a number of families with one of the three common BRCA founder mutations, and BRCA2 is the one that I mentioned. My chief of my service and close colleague, Ken Offit, had found, and so he had a number of these families with the BRCA2 del-T mutation. And what was interesting in those families, they would even be sometimes a small family. One family member would have breast cancer at age 80, and another family member would have breast cancer at age 40. And you knew something was going on, but what? And there was families, tons and tons of families like this, where it just didn't seem to follow this high risk of, and this is BRCA2, which is not quite as high risk as BRCA1, but high risk. And so that led Dr. Offit to work with the laboratory and do these modifier gene studies, which are obviously been done all over now and published, but it's something that we've identified. Then there are modifying genes that can also play a role in mitigating the risk, where the individual that had the earlier age diagnosis had, something kind of tipping that scale, if you will, versus the patient that just had a more general population age, diagnosis, meaning diagnosed at age 80 or later in life, didn't have the modifying gene. That makes sense. And sometimes they're protective modifiers. Sometimes they're, play a different role of increasing risk.
So basically, we're looking at genes that are controlling cell division, continuation of cell division, and we know that cancers are uncontrolled cell division within a tissue. Yes. And so the BRCA gene basically is something that prevents the continued replication of cells. Is that correct? Mm-hmm. And so having the BRCA1 or BRCA2 means that genetic mechanism, and I'm saying this because I'm not sure.
No, you're right.
Genetic mechanism is no longer working, and so the BRCA is a broken functioning gene. Is that correct?
It's not functioning properly. Yes.
Yeah.
Because its normal function would be, like you described, kind of to suppress tumor growth, to stop the cell division. Yeah.
And another question: do all doctors or oncologists, especially, are they tuned into the benefits of genetic counseling, or do they have to be taught about that as well?
It's really changed in my career. I would say now, the doctors here are fantastic and understand what we do in our expertise, understand the field so much more. And obviously, I just think also in the world, patients understand so much more coming in because of awareness that's been improved. They may not know what genetic counselors do, but they know what genetic testing is to some extent. When I think it was something that we had to demystify. We had to spend a lot of our time with healthcare professionals, providers, to refer to us and explaining. I think genetic discrimination was something that was a concern back at early 2000s, for example, of how this information may be used against them if they tested positive. And there weren't the same federal laws in place that there have been now for many, many years. But I think providers have really come a long way in their knowledge and understanding, definitely. So I'm biased. I'm lucky at this institution that we have such knowledgeable professionals, but even from everywhere, far-reaching, the physicians and healthcare providers have a good understanding of who they should be sending to us, or obviously can reach out to us and learn from that. And it's been amazing. I think improved immensely is what I would say in terms of knowledge of everyone.
Well, you brought up an interesting point, and I feel like this is a conversation between you and I, but that's okay. I taught a couple of courses on bioethics, and one of the big issues or chapters within a bioethics course is the information from genetics and genetic testing getting to insurance companies, for example. How has that changed? You kind of hit on that a little bit.
Yeah. So always the concern was that if you had your insurance pay for something, they could ask for the results, if that makes sense. And so with health insurance, we didn't have protections in place that now, with the Genetic Information Non-Discrimination Act, have been in place since like 2006, I think it was, that protect against the misuse of this information by employers or by health insurers. It kind of covers a lot of the gamut of this. So that's been really helpful because, again, we didn't know. But the other piece that we've always tried to explain to health insurers or providers is that we all carry mutations in genes, whether it's, for cancer, for something else, for some type of disease, that this isn't just like, a siloed group, if that makes sense, that could be discriminated against for any reason. So I think that that's something the insurance recognizes more and more with many disease types, and certainly with cancer. They also then are much more willing to cover the testing when they recognize the medical benefits to the patient and effective cost efficiencies of having a preventative surgery is something that really has come a long way too. And
going to save them money in the long run.
Exactly.
Yeah.
A little bit different, something that we always say then for, because that was kind of health insurance pieces, but for, I'm blanking on the name of like longer term, not disability,
long-term care insurance.
That's something we still recommend the patients get a policy in place before testing if they're unaffected and young and haven't had a policy, just to have that policy set up at a certain time. Obviously, after somebody's already had cancer, genetic test results aren't going to make them more high risk in that regard. But those policies aren't the same as under the Genetic Act.
And I think my last question is, you talked about immunotherapy, and I've worked with one of the pioneers in immunotherapy on some education stuff. Are there certain genes that are better for immunotherapy than other genes?
Yes. And that's where I should have my close colleague and friend Sophia Stadler gives talks on this all the time because she's a GI oncologist and specialized in genetics, and so it's something that we've come a long way with different GI cancers treatment.
Very good. Anybody else have any other questions? Because Megan and I can talk for hours on things, and I know she has clinical things going on. Anybody else in the group with questions for Meg? Well, if not, then I want to thank you very much. I wish there were more people, but it will be on the YouTube channel, and I'll send that out to pretty much everybody in the world. They can tune in, and they can't ask questions then, but they can certainly see your presentation. And I want to thank everybody for signing in, and like I said, thank you very, very much for doing that. And we're getting a couple of chat things, and it's an excellent presentation from Judy. So again, thank you. And I'm going to stop the recording then. If anybody has any announcements, I don't know if Steve is still on. If he has any announcements, he's probably in North Carolina by now. But I'll stop the recording at this point.
Thank you.